And welcome back. Now we're going to talk about some genitourinary, or I call them GU, alterations in children. And like I've done with every other system, I always highlight the differences in the pediatric realm versus what you know from the adult world. All renal structures, including nephrons, are present at birth. Yay! Over the first 5 years of a child's life, those nephrons grow in size, not in number, and they mature. Bladder capacity of children is about 20 to 50 mLs at birth and increases as the child grows. A 6-year-old has about an 8-ounce bladder capacity. All you do is add 2 to the child's age, and that should be about their bladder capacity. Children less than 2 are generally not potty trained because of insufficient nerve development to control the muscles needed for bladder control. So these are the common diagnostic tests that they use in pediatrics to test the GU system. There's a great table in your book that I've referenced on your slide, so please take time to look at that. If you are not familiar with any of these things, then please read up on them. If you are familiar with them and know exactly what they are, you just breeze right through. I will highlight the urodynamics because you guys may not have seen that before. Urodynamics testing basically tests the efficiency of urination. They check to see if the muscles with voiding are working in collaboration with each other or not. For example, as the bladder contracts and squeezes the pee out, the urethra needs to relax to let the pee flow out. Sometimes they should work together so that when the urethra contracts, so it does not let the pee out, then the bladder can relax and allow the urine to fill the bladder. However, sometimes these muscles don't work well, and so you can get bladder spasms, or urethral spasms, or as the bladder is squeezing and contracting, then the urethra is also squeezing, and so kids aren't able to get all of their pee out at a time. That would be called bladder dysfunction, and there's physical therapy for that. All right, so let's talk about UTIs in children. They can occur in the lower or the upper urinary tract. Lower UTIs are called cystitis, or bladder infections, or urethritis. Upper UTIs are called pyelonephritis because those affect the ureters and the kidney. You can have asymptomatic bacterial UTIs. Simply put, you have bacteria in the urine but no symptoms. You can have recurrent UTIs, which is repeated episodes or symptomatic UTIs. You can have persistent UTIs, which is infection that persists despite antibiotics. Those are pretty scary. Febrile UTIs, usually the presence of a fever indicates pyelonephritis, so that's a pretty serious UTI. Pyelonephritis ends up, sometimes kids end up hospitalized with that. We also have cystitis, which is just inflammation of the bladder, different than an infection. Then we have urethritis, which is inflammation of the urethra. We talked about pyelonephritis, which is inflammation of the upper urinary tract and kidneys. Then we have urosepsis, which is a febrile UTI with systemic signs of bacterial illness plus a positive blood culture. So that's sort of the cascade. And the common culprits are listed for you on your slide. So what we know is that urinary stasis increases the incidence of UTIs. Urinary stasis is when kids don't get all their pee out. So the two most common causes of urinary stasis would be neurogenic bladder. These are the kids that pee all the time, just like a little bit. As babies, they just pee constantly, like all the time. They just like pee, and a few minutes later, just like a little bit more pee comes out, and then maybe a little bit later, a little bit more pee comes out. Sometimes the children who usually have a neurogenic bladder are those who are affected by spina bifida. Urine is supposed to be sterile, right? The body tries to keep it sterile by diluting it out to decrease any possible bacterial load. Bacteria usually prefer an alkaline environment, and pee is just naturally acidic. There is some evidence that suggests that daily concentrated cranberry juice will increase the acidity and therefore decrease the incidence of UTIs. The other common cause of urinary stasis, I'm going to jump back to this, is the vesicoureteral, that's a really hard thing to say, vesicoureteral reflux. It's just easier to call it reflux. It's the backflow of urine up the ureter during voiding. So what happens with reflux is, pee comes down the ureters, it enters the bladder. Then as the bladder fills, then you should have these little like one-way valves that seal over where the ureter enters the bladder that prevents the pee that's in the bladder from going back up the ureter back towards the kidney, right? Because it should just be a one-way street. We don't want a two-way street, we want a one-way. So in reflux, what happens is sometimes those valves are either absent, or they're not there, or they're just not functioning like they should. And so as the bladder fills like a balloon, the pee starts inching its way back up the ureters and causing reinfection. So that is something we can fix with surgery. We'll talk about that in a couple slides, I think. Other causes of UTIs, constipation. This is a big one for kids. If kids are not pooping, then they're going to get a UTI. So if they need to go on Miralax, if they need to go on Milk of Mag, if you need to clean them out with that magic mousse I told you about in the GI slides, whatever you got to do, but the poop has to come out because constipation is a big risk factor for UTIs. Poor hygiene, kind of. Uncircumcised males, sexual abuse, activity, or masturbation is one too, especially if kids are, doing that without kind of washing their hands first. And then also that bladder dysfunction, that bowel and bladder dysfunction that I kind of talked about already, that you find out with the urodynamic testing. That is another thing. Why is constipation such an issue? Because it can prevent the bladder from emptying, because it's, the bladder can't empty all the way if there's, a big ol', turd sitting in the intestine that's blocking it. And not to mention the gut just harbors bacteria naturally. So you should also know that little girls have a shorter urethra, so it's a shorter pathway for infection. So it's really easy for that bacteria, especially if girls are not pooping. If you have a full gut and if somebody's not pooping, it's real easy for that E. coli bacteria to just march its way kind of out of the butt and straight up the urethra, and you end up with a UTI. And there is a higher incidence of infection among uncircumcised boys younger than 3 months of age. All right, so why do we even care about UTIs in children, besides the fact that it makes them pee a lot and it hurts? Because it can lead to renal scarring and hydronephrosis. I know you all remember that renal scarring is associated with poor renal function, which is going to affect hypertension, proteinuria, and end-stage renal disease. So it really is a big deal. In fact, the risk of renal scarring increases with UTIs in children less than age of 1. A delay of diagnosis and treatment. It increases with structural defects and nerve innervation issues and recurrent UTIs. So UTIs in kids really are a really big deal. Symptoms. Let's talk about symptoms for a minute. In babies, you're looking at a fever, hypothermia, because remember, babies don't generally run a fever unless there's unless they have something really bad, like herpes in their CSF. Generally, babies don't run fevers. But on the flip side, they will get cold. So hypothermia is a risk factor. Again, possible fever. Failure to thrive, poor feeding, vomiting, diaper rash, and diarrhea. Toddlers will often have the classic symptoms: stinky, cloudy pee, painful urination. They may pee and then fuss and cry or just scream as they're peeing on the toilet. Some UTIs are silent and just discovered on a routine well-child checkup. Diagnosis, you're going to have to collect the pee at some point. So you can collect a UA. How do you collect a UA from a child? Well, it can be collected in a variety of ways. You can do a cath specimen, but we don't like to do that if we can avoid it. So we try and avoid it at all costs. A midstream clean catch is a good way. You can do in babies, you can do a suprapubic bladder tap if you've been trained, but that's kind of you have to be trained to do that. Another way you can collect pee in a baby is just, stick on a wee bag, and that's kind of the easiest way to catch it in a baby. Treatment. Well, we basically just need to eliminate the current infection. So we're going to treat it with Bactrim, which is your sulfonamide, cephalosporins, nitrofurantoin. That's a really great antibiotic because it doesn't really affect children systemically. It just kind of just goes in the GU tract. So that's kind of a cool antibiotic to use. Or we can use penicillins too. It's important to identify what caused the UTI to hopefully prevent future ones, prevent the systemic spread of the infection. If they've had pyelonephritis, they may need to have a renal ultrasound just to make sure their kidneys are still okay. And then again, we're going to push fluids, try and preserve renal function. If we're hospitalized, they'll be on IV fluids and of course, INO. All right, so let's talk a little bit more about reflux. As the name reflux suggests, there is a reverse flow of urine up from the bladder to the ureters. This happens when the ureter opening at the point where the ureter joins the bladder does not close off like it's supposed to when the bladder is full. This causes a UTI. That bacteria can infect the kidney and cause renal scarring, hypertension, and chronic renal failure. When you look at this picture, you can see how when the bladder fills, the ureters are supposed to be pinched off. With reflux, they are not. And there's some different grades too. We'll talk about that on the next slide. All right, so reflux, it ranges from grade 1 all the way up to a grade 5. Again, you can usually presents as just frequent UTIs. And by frequent, like frequent, you pretty much stop antibiotics and within a very short time they're reinfected. When my daughter had reflux, we would stop the medicine, and within 48 hours she'd be positive for a UTI again. So we went through lots and lots of antibiotics and testing for this. The goal in the treatment is to prevent the UTIs and prevent renal scarring. This can be managed with prophylactic antibiotics. So just a once a day antibiotic just to knock the bacterial load down and try and prevent future infections. Surgery can be done to correct the angle that the ureters enter the bladder. There is also a newer treatment that's called the Deflux Procedure. So this Deflux procedure can be used to treat reflux from grades 1 to 4. Basically, they go up through the urethra to the ureter and they inject the sugar-based gel within the wall of the ureter. That makes a bump that helps prevent the backflow of urine. I will share with you, my daughter had grade 1 reflux just on one side, and we opted to have the Deflux procedure done when even while she was on prophylactic antibiotics, she still ended up with the UTI. We ended up in the hospital with pyelonephritis. It's a big deal. So the pediatric urologist in St. Louis said, we should just fix the reflux and we'll do it. So we opted for the Deflux because it was the least invasive and her case was so mild. So there's some cute pictures of her. She had it done when she was, I think she was 4. Pretty sure she was 4 because all her issues started when she was 4. So here she is, a cute little 4-year-old at St. Louis, Mercy Hospital in St. Louis. It's not St. Louis Children's, it was Mercy Hospital in St. Louis. There's the first picture is her pre-op, and then they gave her a little cocktail of some Versed that made her pretty happy and pretty sleepy. They took her off to surgery in a cute little wagon. And then post-op, here she is. She woke up a little on the cranky and irritable side, but she still to this day remembers eating 2 orange slushies afterwards, and she loved it. As far as parent teaching goes, like discharge teaching after surgery or for something like this, make sure that you tell them to push fluids, lots and lots and lots of fluids. You've got to encourage these little kids to drink a lot because they don't want to. Pee every 2 hours. You almost just need to set a timer on your watch, but pee Q2. Avoid constipation. So your choices are fiber gummies, milk and magnesia, Miralax, whatever you want to do, but you have to make sure your child is pooping. And just pooping every day is not enough. You need to look at the Bristol formed stool chart. And you want to make sure your pooping is at level like 4 or 5. You're kind of shooting for somewhere in the middle. If they're pooping corn cobs out, but corn cobs every day, well, they're constipated. So we also don't want them pooping gravy out either. So, there's a happy medium in there. Double void. So what it means to double void is kids have to sit down on the toilet and they pee as much as they can. And then they want them to sit there and take some big deep breaths in and out several times. It also helps if kids kind of lean forward a little bit. and that's something we learned from doing bladder, or from doing like physical therapy with my daughter. Um, but the deep breaths, you take a big breath and you blow it out like you're blowing out birthday candles. Basically, just take a big breath, blow it out, do like 4 or 5 of those big deep breaths, and then you have them try and pee again and see if they can get any more pee out. Dietary restrictions: avoid dairy products, avoid artificial sweeteners, artificial colors, avoid soda pop, avoid carbonation, avoid spicy foods, avoid red food dye. They were going on and on. They'll tell you to avoid citrus foods. At one point, when they were telling me all the things to avoid, I looked at them, I said, "What do you want me to feed my child?" And the nurse kind of laughed and she's like, "Well, I guess meat and vegetables are okay." And I said, "And you have a child? Like, do you understand?" I said, "But if I give her meat at every meal, then someone's going to yell at me about giving my child too much, meat. So what do you want me to feed her?" And she's like, "Well, moderation." I'm like, "Yeah, whatever." So those are your teaching points. All right, so obstructive uropathy is pretty much exactly what it says. It's a structural or functional abnormality that obstructs normal flow. You end up with backup of urine, which causes hydronephrosis in the kidney. Condition, you can read through that. Basically, and I just put a graphic on here just to show the common sites for urinary tract obstruction. All right, so now we'll talk about some other defects of the GU tract. I'm going to reference table 44-4 in your book to look over this information too. Inguinal hernias, you already know what this is and you know it's fixed surgically. Hydroceles, that's when you get fluid in the scrotum. Again, it's fixed surgically. Phimosis, that's the narrowing or stenosis of the opening of the foreskin. Hypospadias is when the urethral opening is on the ventral or the underside of the penis instead of being at the tip. Epispadias is when the urethral opening is on the dorsal or like on the top side of the penis when you're looking down. You can have defects involving the chordae. You can get a ventral curvature of the penis. It's often associated with hypospadias. This is going to be fixed with the surgical release of the banding that's causing the curvature. Then you can have cryptorchidism. That's how it is. It's cryptorchidism. Basically, it's a fancy name for undescended testes. Usually just time. You just allow some extra time and the testes will descend on their own. They can do surgery, or sometimes they can fix it with some HCG hormone if it's in an older child. Then we can have issues with the bladder. I shouldn't say I've seen cases, because I really haven't, but you can have cases where the bladder protrudes through the abdominal wall. So the bladder is kind of like on the outside of the belly instead of tucked in way inside. This is going to be something that has to be fixed surgically. And then sometimes we have ambiguous genitalia, and that's when the full differentiation of genitalia does not really occur. And so sometimes it's kind of difficult to judge and say if a baby is a boy or a girl because you don't always know. But what they will do in cases like that is they'll do blood testing and see what the child's chromosomes are, so they know definitive, and then they can do ultrasounds and they will look for, a uterus and ovaries and see exactly what this child has. So epispadias and the bladder exstrophy often occur together. Bladder exstrophy is very rare, which is good, and it's when the bladder extrudes through the lower abdominal wall. I kind of already talked about that. Females can also have a epispadias with a urethral cleft that extends into the bladder. Corrective surgery is usually done around 1 year of age, or at least by the preschool years. All right, if a child has a hypospadia or an epispadia, that child is not eligible for a circumcision while they are in the hospital. And the reason is the doctor will need that tissue for the surgical correction later on. Surgery is usually done between 6 to 12 months of age. We're looking at our standard post-op care. What do we always look for? We monitor for signs and symptoms of infection. We monitor and administer pain medicine. We're going to check vitals frequently. We're going to administer IV fluids, and we're going to monitor their INO. Basic post-op care, right? Sometimes kids may have stents placed to maintain urethral patency. Again, we're going to monitor urine output and stent patency to prevent the child and make sure that you prevent the child from possibly removing the stent. Discharge teaching, let's talk about this. This is a biggie. No tub bathing until the stent is removed. No riding toys. Generally, if anybody has any kind of, surgery down there, they're going to say no riding toys. And that includes don't carry them around on your hip either. Limit the activity for 2 weeks post-op. Don't let them be super hyper. We want to encourage fluids. Complete the round of antibiotics that they will be on. Watch for signs and symptoms of infection. We're looking for fever, redness, swelling, pain, stinky pee, a change in the urinary stream, things like that. It's normal for the urine to be blood tinged for a few days post-op. Call the doctor if the urine is leaking anywhere other than where it should be coming out.